Thank you, Mr. Chairman, and good afternoon. Glad you guys have hung in. We've heard a lot about RV failure on and off throughout this talk, and what I want to discuss today is the assessment of RV function and then subsequent RV failure after LVAD implantation. I have no conflicts to disclose. So some of the questions that I hope to answer during this talk is RV failure a major issue in modern day MCS therapy? Do the determinants of RV function differ in patients who have VADs when compared to patients who don't have VADs? And do we have the appropriate tools to predict RV failure after LVAD implant, both early and late? And also, do we have the tools to properly assess RV function in ambulatory VAD patients? Finally, what options do we have available for treatment and prevention of RV failure post-LVAD implant? So in the US, here are the three pumps that are currently, durable pumps, which are currently available for use. The HVAD pump and the HeartMate 3 are centrifugal pumps, and the HeartMate 2, which is making a slight renaissance, is an axillary flow pump. So you understand, you've heard about the benefits of mechanical support from Dr. Ledley to restore circulation and hopefully preserve end organ function. And we've seen from the ISHL2 registries that survival after LVAD implant is very impressive. For the BTT group, 85% at 1 year, 77% at 2 years. And for the DT patients, 78% at 1 year and 66% at 2 years. But what if you look at patients who actually need biventricular support? Well, their outcomes are a lot worse than people who can get away with just LVAD support. So for continuous flow BiVADs, the 1 year survival is 55% compared to the 85 that I showed earlier. And when you look at the total artificial heart, the 1 year survival is only 50%. These are patients who are being bridged to transplant. So in terms of our first question, is RV failure a major issue with our modern day MCS therapy? And the answer remains yes. So the disparity between patients who need RVADs or BiVAD support versus LVAD support remains vast. In terms of defining what RV failure means, so just so that we're all on the same page, I use the Intermax definition of RV failure, and an Intermax, which, as you know, is a database that Dr. Hong talked about, IMAX, which is a database that Dr. Hong talked about earlier. They have strict definitions for diagnosing RV failure, and patients are followed through their index hospitalization, and then at 1 month, 3 months, 6 months, and then semi-annually thereon. So they have a lot of data on what happens with these patients in the immediate post-op period and through the life of the VAD. So the first thing you have to meet the definition of RV failure from Intermax is an elevated CVP, and that can be obtained invasively or non-invasively. But the first step is to have an elevated CVP, and to go along with that, of course, the clinical manifestations of RV dysfunction, which are peripheral edema, ascites, or evidence of worsening end organ function with increases in bilirubin and worsening renal function. Once you make the decision that the person meets the criteria for right heart failure, they then characterize it by mild, moderate, or severe. In addition to that, they delineate it between acute and then during the surveillance period. So if you have, in terms of mild right heart failure during the implant admission, these patients should be weaned off inotropes in the first 7 days, and so that's considered mild. During the surveillance period, so that's through the life of the pump, they have no readmission since the last surveillance period and have not required inotropes. So that's mild RV failure. In terms of moderate, those are patients who during the implant require intravenous vasodilators or nitric oxide for 7 to 14 days. So that's moderate. In terms of the surveillance period, if they've had an admission during that since the last screening period, just one admission, then they're considered to have moderate RV failure. In terms of severe, these patients require IV vasodilators, nitric oxide, et cetera, for beyond 14 days. That's the severe group. In the surveillance period, once you're an ambulatory patient, RV failure is considered to be severe if you've been admitted at least 2 times for heart failure and required intravenous medications. Of course, if you require RVAD support, or if you die from RV dysfunction, as an ambulatory patient. In terms of severe acute RV failure, so this is the one that the surgeons really want the cardiologist to get right in terms of predicting who this would happen to. These are the people who were sent to the operating room for an LVAD and end up requiring a RVAD at some point, or for patients who die in the ICU from RV failure. So in terms of the risk factors for developing death after LVAD placement, so we sort of talked about this yesterday. Patients who are dialysis patients are at high risk. Patients who require an RVAD at the same time, not planned. And then, of course, patients who are cardiogenic shock or NMX profile 1. So in terms of the determinants of RV function after LVAD, this is really interesting and fascinating in terms of how we look at things from a cardiology standpoint. So the question is, do the determinants of RV function differ in LVAD patients? So I'll go to here. So yes and no. So as we know, the RV, this is a normal heart. The RV is very afterload sensitive, so stroke volume drops as afterload increases, more so than with the LV. And the classic sort of description of how we develop RV failure, this is actually from a recent publication in Circulation, which is fabulous in terms of understanding RV physiology. But the general consensus is that in terms of RV failure in the setting of left heart failure, that the issue is an increased LV-EDP, which increases afterload and then causes poor performance in the RV because of the increased afterload. So this ends up with RV dilatation, in addition, increased wall tension, decrease in stroke volume because of the Frank-Starling mechanism. So takeaway point from this in left heart failure, the primary determinant of what happens with the right heart is LV-EDP. Also, when you look at RV physiology, there's this concept of ventricular interdependence. So as the RV becomes dilated because of high afterload, the LV is compressed, and preload to the LV decreases. And this is due to the pericardial constraint. If you look at this after LVAD, this is where it gets interesting. The LV afterload is decreased immediately with an LVAD. So the question becomes, why does the RV dilate and why does it fail when you have decreased the LV-EDP? And we know that from hemodynamic data post-LVAD and also echo data that yes, when the LVAD goes in, cardiac dimensions decrease. This is from echo data. Cardiac dimensions decrease, and actually LVEF increases slightly because the LV is unloaded. But when you look at RV parameters, right ventricular parameters, at least 1 month after LVAD, the CVP really hasn't changed. It's not until about 6 months out that the CVP begins to normalize. So just like the previous slide, even though the LV is decompressed, the RV continues to struggle somewhat. As you would expect, early after LVAD, or 1 month point, your wedge pressure is decreased and also is pretty much normal by the 6 month mark. And what's interesting is everything we've been taught about if you drop the PVR, your RV function should improve. It doesn't necessarily happen with LVAD. So the PVR is lower because the cardiac output is increased, but yet the CVPs remain in the same range as pre-op. So this is just a schematic of our current pump. So here's the axial flow pump and the centrifugal pump, so the HVAD and the HeartMate 2. And pump performance is determined by the pressure across the pump or the pump differential. And so in terms of, we refer to these pumps as continuous flow pumps, but if you actually look at the flow diagram, there is some pulsatility. So because it's variable with the pulse pressure across the pump, as the LV contracts, the flow increases or decreases with the cardiac cycle. In terms of pump performance, in terms of flow, this just shows you at diastole, flows are lower, and higher with systole. So there is some pulsatility there, even though we may not be able to detect it with a pulse, it's there. The other thing in terms of performance of your pump, in terms of flows or pump flows, this is a PV diagram which tells you basically that the pumps are also sensitive to afterload. So as the pressure across the pump increases, your flows decrease. And so that's the same thing as with the native heart, except with LVADs, it's actually much more dramatic in terms of sensitivity to afterload. And this is across all speeds, and the pumps they're showing here are the HeartMate pumps and the HVAD. So this is a nice slide, which is sort of a takeaway as to what's going on with preload and afterload and pump sensitivity. So what they're showing here is that with the continuous flow pumps up top and the native the native heart here, is that your sensitivity to preload in patients who have an LVAD actually decreases, and your sensitivity to afterload increases. So your responses to load are more exaggerated in patients who have LVADs. And you may say, well, what does this all have to do with LV? So I'm talking about LV function here. How does this translate into what happens with RV function? Well, decreased RV function is the same thing as far as the LVAD is concerned as decreased preload. So what you see here as the preload decreases with the LVADs, that the flows actually dramatically decrease. So the reason why patients with RV dysfunction do very poorly is because the sequelae of this is poor LV filling and, of course, low flows, which then leads to multisystem organ failure. So the conundrum with patients who have VADs is that even though you decrease the LV-EDP by basically emptying the heart, you don't get the benefit of immediate decompression of the RV. And so when you go back and look at the classic slide of, how do you explain RV dysfunction in the setting of LV dysfunction, with the VAD, we have decreased LV-EDP, but we don't get the benefit, and theoretically, of decreased RV afterload, but we don't get the benefit of decreasing or of improving RV function. And the reason that is because at the same time that you've decreased LV-EDP, you've dramatically increased RV preload by returning all this blood back to a ventricle that's already struggling. So it's the same scenario as if a person with RV dysfunction gets massive transfusions all at one time. So there's no RV reserve to handle the increased volume that you're sending to the right side. Also, as we talked about with the previous slide, because preload sensitivity is decreased in patients with VADs, meaning they don't get the augmentation in the stroke volume with increased filling, you just end up with increased wall tension, ischemia, etc. So in terms of the tools that we have to predict who's going to develop RV failure both early, so in the OR or ICU, and late, we'll talk about that. And then the other thing, as a cardiologist, clinical cardiologist, do we really know what we're doing in terms of assessing RV function in our ambulatory patients? So, let me just show that one again. In terms of what the ISHLT guidelines are for assessing RV function in the pre-implant patient, it's echo, of course. And as I think Dr. Ledley showed us earlier, there's at least 20 parameters that you can use to characterize RV function. But what you really need to understand is invasive assessment of RV function. So the CVP is key here, and that's why when you look at the INTERMACS definition of RV failure, it hinges on what the CVP is. In terms of their management, it's very general. It just says aggressive management, however you can, to do whatever you can to get the CVP down. And once the patient's optimized, meaning that you've gotten the CVP into a relatively normal range, you can reassess RV function and see if you feel that the patient can get away with just left ventricular support. If you don't think the patient, after you've done the best you can do to optimize the patient, if you don't think they can tolerate just LV support, or if there's a question about the patient's mental status, or if they have severe, or if they have multisystem organ failure or sepsis, then you go to your temporary mechanical supports. This is where ECMO or some of the devices that Dr. Ledley talked about, which will give you time to reassess their mental status and see if their end organs recover before you go into to implant an LVAD. So the story with this is, if you're not going to do, if you're thinking about doing DT, this is definitely the wrong group of people to consider for this. Not a bailout. So you've heard about the INTERMACS criteria. So in terms of patient selection, that's always the key thing in figuring out which patients you should refer for LVAD alone, or which patients will need biventricular support. So this slide, also from INTERMACS, stratifies the freedom from severe heart failure based on their INTERMACS classification. So as you would imagine, the sicker patients are more likely to develop RV failure post-transplant. So that's why when you're considering who's going to go for LVAD alone, you want to do everything you possibly can to try to optimize before sending these people to surgery. And this is held up. These are the original guidelines from the pulsatile pump era. So back with the HeartMate ones, and they knew from way back then that the most important exclusion criteria for going for LVAD is severe right heart failure, elevated CVP, elevated PVR. So all these things are well known, and the only thing that's changed over the generations is the type of pump that we're using. Speaking of the type of pump that we're using, this is the incidence of RV failure in our most recent VAD trials. So the endurance trial, which is the HVAD trial, and the momentum trial, which is the HeartMate 3. So what they found in the hardware trial is that the percentage of patients who developed right heart dysfunction in both the study and control group was anywhere from 38% to 26%. So that seems pretty high, especially in an age where we have a lot of experience and should know how to choose people for going for LVAD. But what they do show is that the people who actually need an RVAD, which to me is the most important part of miscalculating, is pretty low. So 2.7% to 3.4%. So even though patients had RV dysfunction by INTERMACS criteria after pump implantation, very few people had to go on for VAD support. And the same thing is true in the HeartMate 3 trial. So what about risk scores? So back in the rematch, back in the pulsatile pump period, we had something called the Leeds-Miller criteria, and they recognized then from the data that multi-system organ failure, stroke, and RV failure were key determinants in patients dying after LVAD implantation. This is a new version which was recently published from the European experience. It's from EuroMax, and they have a score which they've developed to predict which patients will develop right heart failure at the time of surgery. And just to show you in terms of patient characteristics, relatively young group, people in their 50s, mostly male, and they were in their cohort, the patients were predominantly INTERMACS profile 2 and 3. The other interesting thing about using this risk score is you'll notice that in terms of baseline characteristics, their patients were already quote unquote optimized. So their CVP was 11 to 9 in the derivation and validation cohorts. So these patients were optimized when the score was applied. They had elevated wedge pressures as you would expect, and severe RV dysfunction on echo. So in terms of their risk score, they looked at the 5 major causes of death in their cohort, and for patients who had right heart failure, by their definition, the mortality was higher than those who did not in terms of multi-system organ failure and sepsis. Really no difference in the others, such as stroke, bleeding, or cardiopulmonary failure. So in terms of the parameters that go into their risk score, you see them here. The big one, which is most people use clinically, is RV power, which is RA over CVP, the ratio of greater than 0.5. Hemoglobin of less than 10. I think that has to do with, is this patient going to require a lot of transfusions? Of course, patients who need multiple inotropes, INTERMACS class 1 through 3 gave you a higher risk, and of course, evidence of severe RV dysfunction on non-invasive testing. They also did another analysis on patients and added in how long they were on bypass. So what did they find in terms of how this score is able to delineate which patients are at high or low risk? So for patients who had a score of greater than 4, the development of early severe right heart failure was very high. And for those who had a low score, it was around 10 to 12%. When you go in and look at cumulative survival by stratifying by this score, the patients at higher risk, of course, had a lower survival as compared to those who were low risk. So this score actually seems to be something that's going to be very useful in helping people figure out who to take to surgery. But I just remind you, it was applied to people who were optimized. What options are available for treatment and prevention? So in terms of, I'll skip this since we're running out of time. In terms of concomitant surgery, so they recommend that patients who have tricuspid valve regurgitation, that if you can repair it at the time of the RVAD or LVAD, please do. In terms of this function of when you decompress the LV, the RV is dilated, becomes dilated. The way to handle that in the early pre-op or peri-op period is to have your patients come out of the operating room with low flows, and a lot of places do frequent echo studies to make sure that you're not flooding the RV in the early post-op period. And then the whole thing about blood pressure is very important in your ambulatory patients what they're trying to manage, because remember, these pumps are afterload sensitive, so you want to make sure the blood pressure isn't high for that reason, for heart failure reasons, and also for development of stroke. So just one of the things to remember, if the patient does not have a pulse, then the systolic pressure, the Doppler pressure, the mean pressure are all about the same. If the patient does have a pulse, then the Doppler pressure is closer to the systolic blood pressure. And this is just a schematic repeating what I showed you in the prior slide. I'll go to this since I'm running out of time. Let me just go to the conclusions since we ran out of time. I know people have questions. Some of the conclusions from this talk are that RV failure after LVAD placement remain a major risk factor for mortality and morbidity. Though intrinsic LV function is less important during LVAD support, adequate residual RV function remains critical. Determinants of RV function in VAD patients remain the same, though the physiologic responses to loading conditions differ. We have many tools to assess RV function, including multivariate risk scores, echo, hemodynamics obtained from patients, but they should be optimized at the time that you apply your risk stratification. In ambulatory patients, similar to heart failure patients, optimizing cardiac output requires a balancing between loading conditions for both the RV and the LV. In heart failure, this is achieved by using neurohormonal blockers, but in VAD patients, we know that rapidly unloading the LV is actually dangerous because it may reload the RV and flood it, basically. In terms of treatment and prevention options, what I was going to show in the last couple slides are that some groups are actually looking into using hemodynamic assessment to modify RV and LV function. So they're actually advocating that you use swans and echoes to optimize flows and outputs for these patients. At the end, that hasn't been proven, so I would say stay tuned. Okay, thank you.